Hello everybody! The scope of this course is to present briefly the anatomical and functional basics for research-focused echocardiography. In this presentation, I will be focusing on two specific echocardiography views, the apical 4 chambers and 2 chambers. The apical 4 chambers view allows a good overall view on the heart. I will now present the most important structures, starting from the top right and proceeding from clockwise order. We have the left ventricle, the papillary muscle, the mitral valve, the left atrium, the interatrial septum, the right atrium, the tricuspid valve, and the right ventricle. The apical 2 chambers view allows an overview of the left heart chambers. From top to bottom, we distinguish the left ventricle, the mitral valve, the coronary sinus, and the left atrium. Three other structures are also worth mentioning, as they are fundamental for the measurement of some parameters of heart function, such as the ejection fraction and myocardial strain, and for the identification of some pathological states, such as pericardial effusions. The endocardium is the innermost layer of tissue that lines the chambers of the heart. Its cells are embryologically and biologically similar to the endothelial cells that line blood vessels. The endocardium also provides protection to the valves and heart chambers. The outer layer of the heart muscles is termed epicardium, while the pericardium is a double-walled sac containing the heart and the roots of the great vessels. The pericardial sac has two layers, a serous layer and a fibrous layer. It encloses the pericardial cavity, which contains pericardial fluid. At the ultrasound examination, its appearance is usually hyperechoic, and no fluid should be macroscopically visible between the two pericardial layers. The presence of an anechoic space between the two pericardial layers is the hallmark of an abnormal fluid collection termed the pericardial effusion, as evidenced by the two red arrows. For our purposes, it is also important to know how to distinguish the individual segments of the left ventricular walls. In the apical 4 chamber view, starting from bottom left and proceeding in clockwise order, we distinguish the basal septum, the mid-septum, the apical septum, the apical lateral wall, the mid-lateral wall, and the basal lateral wall. In the apical 2 chambers view, starting from bottom left and proceeding in clockwise order, we distinguish the basal inferior wall, the mid-inferior wall, apical inferior wall, the apical anterior wall, the mid-anterior wall, and the basal anterior wall. The sum of the segments we have seen so far forms a 12-segment model of the left ventricle, which we employ to describe the overall left ventricular systolic function through speckle tracking-derived strain analysis. ECG tracking during echocardiography serves mainly the purpose of recording heart rate and allowing for the identification of two main phases of the heart cycle, systole and diastole. The three main ECG waves we are interested in are the P wave, which corresponds to atrial depolarization, the QRS complex, which corresponds to ventricular depolarization, and the T wave, which corresponds to ventricular repolarization. Most anatomical and functional measurements have to be performed either at the end of ventricular diastole or systole. The end of ventricular diastole corresponds to the end of atrial systole and can be identified on the ECG as the beginning of the R wave. The end of ventricular systole, instead, is identified by the end of the T wave. In addition to ECG tracking, other clues can be employed to identify the end diastole and the end systole phases. In particular, the end of ventricular diastole is also marked by the closure of the mitral valve, which is followed by the so-called isovolumetric contraction and the opening of the aortic valve. The end of the ventricular systole is marked by the closure of the aortic valve, which is followed by the isovolumetric relaxation phase and the opening of the mitral valve. The main traditional marker of left ventricular systolic function is the ejection fraction. Its calculation, as shown by the formula, requires the measurement of the end systolic and end diastolic volumes in both the apical 4-chambers and 2-chamber views, thus obtaining the biplane Simpson's ejection fraction. The result is a percentage which is directly related to overall systolic function. Ejection fraction is considered normal when above 50%. A reduction in ejection fraction below 50% leads to different degrees of systolic dysfunction, as shown by the slide. In the same way for ejection fraction, it is also possible to measure left atrial volume at end systole with the biplane Simpson's method. While practicing echocardiography on research patients, it is possible to encounter some pathological states that need to be reported to the patient's attending physician. The two most important pathological states that need to be taken into account are severe left ventricular dysfunction, marked by an ejection fraction inferior to 30%, and pericardial effusion. On this last slide, you will find useful links and resources for further study. Thank you for watching.